Really pleased to be able to offer this lecture for you. I remember when this article came out and I heard about it, I was really excited, and now that I am your course director, I have the distinct pleasure to have the authors actually here today. First, before we get started, we do have a special guest, and one of the co-authors and a former chair of this department and had taught here at TCOM for quite some time. 22 years, Dr. Jerry Dickey is here with us.
And don't blame me, but I was the residency director, so, you know.
Yes.
Take it to the current administration. I'm retired now.
He says not to blame him for me since he was my residency director, if you couldn't hear that. So without further ado, it is my pleasure to introduce to you Dr. I know you know her already, but Dr. Patricia Gort. She is Assistant Dean for the Graduate School of Biomedical Sciences and Professor.
From last year. You probably thought you were done with me, but I keep coming back. It's been a while since I got to look at this study. It's been a few years since we had it published, but it's brought back a lot of really fond memories working with Dr. Dickey and Dr. Vick, who you never had an opportunity to meet, but they're both really incredible physicians. When I first came here, and I'm not going to say how many years ago, I was your typical basic scientist, and this was a great place to work, and they gave me animal facilities to work with chronically instrumented dogs, and that's why I came. I could teach physiology. I was ignorant about what osteopathic medicine was all about, but these folks came and talked to me and told me what they could do, and I said, you have got to be kidding. There is just absolutely no way. So we designed a study to examine whether there is a viscerosomatic interaction that we can induce by myocardial ischemia. The team that I worked with was Dr. Dickey, Dr. David Vick, and Dr. Brian Forsman. Maurice Williams was a graduate student in my lab at the time, and he now has a PhD and is probably making a whole lot more money than I am in a drug company. But I put a number of slides here just talking about the historical foundations. I'm going to skip through some of that. Our research was funded by the American Heart Association, National Institute of Health, and the American Osteopathic Association. So it's been well funded to conduct this research. But what I was told is that you can use palpation and manual medicine to examine sympathetic pathways that exist between visceral organs and the somatic nervous system along the paraspinal muscles. And it was like, you can what? There was just no way. So we designed this experiment to prove that. There's a lot of studies out there in the literature which state that patients with myocardial infarcts have somatic dysfunction between T2, T5. But some of the problems with those early studies is there were no controls. And in this model that I will present to you, each dog is going to be used as its own control. We're going to study them in the normal state and while they're experiencing some myocardial ischemia. But manual medicine theories is that the interactions between visceral organs and somatic responses are mediated by sympathetic nervous system. How are you going to prove that? How do you know it's due to sympathetic nerves? There's an importance in sympathetic nerves in the response to any kind of stress, such as myocardial ischemia. And I had the perfect model to test that. So that when you're undergoing myocardial ischemia, you're going to be experiencing increased skeletal muscle tone due to the enhanced sympathetic nervous system activity. With the somatovisceral or viscerosomatic reflex, there's a chronic, persistent, nociceptive neurological input to the dorsal horns from both somatic nerves and autonomic nerves that drive an efferent impulse to both somatic and visceral end organs. So if their theory is correct, then manual palpatory assessments of those paraspinal tissues should correlate with myocardial ischemia, the visceral organ dysfunction. So we designed this study to induce myocardial ischemia, and hopefully the physicians, Dr. Dickey and Dr. Vick, could detect a cardiosomatic response in the paraspinal muscles of T2 to T5. And they were just going to use normal palpatory techniques. And then if I had a group of dogs where I cut or I destroyed all the sympathetic nerves going to the heart and from the heart, that reflex would be absent. So we receive a number of impulses that come into the spinal cord. Here we have the heart. We're going to make it ischemic, and a number of signals are going to come from the heart into the spinal cord. It's going to synapse in the spinal cord. It's going to synapse with a bunch of other neurons sitting there. They're going to ascend or descend. They can go up to the brainstem and come back down. And then in the meantime, they are going to synapse also on somatic nerves and come out to the somatic muscles out here and change the tone or the degree of contraction of those skeletal muscles and change tissue texture and change mobility of things that exist there. And then the clinician will be able to manually palpate those changes. So our hypothesis, myocardial ischemia induces a detectable cardiosomatic response in the paraspinal musculature, which localizes to T2 to T5, and these changes can be detected by palpatory techniques and, as a physiologist, EMG measurements. So we're measuring EMGs, and it is due to a sympathetic reflex. Rationale for selecting this model, we needed a large animal. We needed to be able to have someone put their hands on this dog and palpate changes, tissue changes. We needed to be able to instrument the dog to measure various physiological parameters. So we chose the dog. Did you have a question?
Yes, Dr. Gortz. Were the folks who were doing the palpating of the paraspinal muscles, were they aware of whether or not the dog had had the ischemic changes
No.
or what the
Totally.
No, we were blinded.
I'll get to that a little bit further on. I will explain to you the methods.
Let's let her talk for a while because I'm going to cut her off here in a minute, and
Yeah.
we're both going to talk. So,
These dogs, in order to study reflexes, you have to have a conscious subject. And that means they have to not be under the effects of anesthesia, because anesthesia has been shown to blunt reflexes. They're going to blunt sympathetic reflexes. So these animals had to be awake. So I chronically instrumented the dogs. That way, each dog is going to serve as his own control, pre and post ischemia. That way, we can repeat the experiments. Each experiment on every dog was repeated 3, 4, 5 times with 2 different clinicians making measurements. And we can induce a transient episode of myocardial ischemia, blinded method. So population, we use dogs. Dogs are big, dogs are friendly. The protocol was approved by the Institutional Animal Care and Use Committee here at the school. We didn't choose to use a human population because I doubt there's anyone in this classroom that would want me to put an occluder on your circumflex coronary artery and stenose your artery. And I doubt that I would get that approved by the IRB. So we went with an animal model. We took really good care of these dogs. They were happy to come up to the lab. They enjoyed the interactions with the physicians. They got their treats every day. They gained weight while they were with us, so we took good care of them. They got better care than probably some pets at home. It required some training of the investigators. We had to learn about osteopathic principles and philosophy and what they were doing. They had to learn some of the physiology as well. We had to understand how to work with the dogs and exactly where to palpate. What were the differences between an animal model and a human model? We had to have physicians that were willing to give up one of their lab coats to come in and work with dogs. So in my lab, I still have Dr. Vick's lab coat.
I just used one of yours.
Yeah. Because if they wore it with the dogs, they couldn't wear it back in the clinic. But
We did this on a shoestring.
we did great. Samples, we had, the study I'm going to tell you, 12 healthy mongrel dogs. They were purposely bred. These dogs cost $500 a piece. They're probably cost today, dogs are probably going about $1,000 to $1,500 a piece for purpose-bred animals. They were large dogs. They were social. They had to be willing to sit quietly on a table for 2 hours and to allow them to be palpated and to have manipulation of the paraspinal segments. They really enjoyed that part. That was fun. 2 groups. There was a group where the left ventricle was neurally intact and a group where we sympathectomized the left ventricle. We sympathectomized the dog by applying phenol, a 90% phenol solution, to the surface of the heart. Phenol will go into the tissue about 1 to 2 millimeters and will kill all nerve endings. So the dogs were effectively sympathectomized. It depleted left ventricular catecholamine content about 90%. Like I said, each dog was his own control. We let them sit there quietly for about half an hour, and then we took control readings. Then I would stenose the coronary artery. During these experiments, I was the only one that was looking at the strip chart recorder in the computer. We had a barrier so that the physicians and any other student in the lab didn't know what the condition was. I was the one controlling whether there was going to be a stenosis of the circumflex coronary artery or not. So everyone but myself were totally blinded. We induced a transient episode of ischemia, and like I said, it was blinded.
Let them know it was
Yeah.
40%.
No, it was 50, 60%. The occlusion. This is just a schematic cartoon of how we instrumented the dog and what we were measuring. We put a solid state pressure transducer in the left ventricle so that we can measure left ventricular pressure, systolic and diastolic pressure. DPDT is an index of contractility and heart rate. We put a flow probe around the root of the aorta to measure cardiac output. We put a catheter in the aortic arch so that we can measure aortic blood pressure. Sitting here, I would dissect a length of the circumflex coronary artery, and we would put a Doppler flow probe on it, a silastic occluder cuff on it, and then a catheter was implanted right into the circumflex artery so that I could measure coronary blood pressure. And we can inject drugs into the posterior wall of the heart that way. We had a set of piezoelectric crystals, little crystals that one crystal would send a signal at 5 megahertz, the other one would receive the signal at 5 megahertz. And how long it takes the receiver to get the signal would be a nice measurement of how much contraction we would get here in the control region, the anterior region of the heart, supplied by the left anterior coronary descending, and over here in the posterior wall of the heart that's served by the circumflex artery. And I'll show you a figure. And all the wires and catheters came out between the scapula, right here. We avoided the regions where the palpation was going to be taken. This was the only figure I had that could show you the conscious dog. He's on a treadmill and he's getting ready to do an exercise stress test. But the protocol, control data was taken we took EMG signals at T4 and T5, and then a control region T11, T12. We did manual palpatory assessments at both regions. We looked at cardiac function, arterial blood pressure, and coronary blood flow. We then did a 50 to 60% reduction in coronary blood flow, circumflex coronary blood flow, or a sham occlusion, and then after 5 minutes, data was collected again. The dog recovered for about 30 minutes or until cardiac function returned to normal, and then we either did another sham occlusion or coronary stenosis. The order of those was varied. I was the randomizer, so no one else knew what I was doing. It could be on a particular day I did 3 stenosis, 30 minutes apart, or I did 3 shams, or I did a sham and a stenosis and another sham. It was just varied. Because I didn't believe that they were going to be able to tell me when the dog was occluded or not. They were blinded. And I'm going to let Dr. Dickey tell you about his manual palpatory assessment of symmetry of the transverse processes, the mobility, tissue quality. What did he sense in these dogs? And let's see. And there's your rating. Here are your 3 slides.
Testing. Why did we do this in the first place? About 1990, when I was chairman of the department, one day Dr. Gortz came in to talk about something entirely unrelated to this, and she was having a terrible sinus attack. Must have been in the fall of the year, and she apologized for hay fever. And we tried to talk about whatever had brought her into my office until I couldn't stand it any longer. And I said, "How long have you worked for this institution?" And she said, 8 years. And I said, "Have you ever had an osteopathic treatment in your life?" And she said, "No." And at that point in time, our entire operation was on the 6th floor of Med Ed 1, the big building across the street. We had our laboratories, we had our academic offices, and we had our clinic. And I just felt so sorry for her because I knew how she was suffering. And I didn't give her any choice. I didn't ask her permission. I grabbed her by the hand, and if you'll recall, not dragged you, but you didn't know what we were up to.
No.
And led her down the hall. Did not have, I could slip in. I had one of the back treatment rooms in our clinic. Took her in, put her on my table, examined her, began to treat her, began working on her sinuses. And then I said, "Look, you go home," gave her a whole handful of Kleenexes, said, "You're going to need these in a few minutes." And then I said, on your way. The next morning, she was waiting at my door to my office, and she said, "Do you have any idea what you did to me yesterday?" So I realized that this was the teachable moment. And so I remember kind of kicking back in my chair, and I said, "I understand you've got a very interesting dog model that you're doing work for the American Heart Association." And I said, "How about you tell me about this dog model?" And so she did, and this is what she's demonstrated to you. And then I related a story to her, that one of my clinicians at Kirksville, a diagnostic genius by the name of Max Gutensong, my 3rd day as an intern, right after the 1st of July, this MI is brought in. I mean, he looked pretty classic for an MI. He was gray, he was diaphoretic, he was sweating, he had chest pain. But I watched Dr. Mack slide his hands under his upper thoracic area on either side of the neck when he was lying on the gurney. And he just said to him, "Yep, he's infarcting." He walked in, called the unit, made sure they had a bed. They're getting an EKG on him. They're drawing cardiac enzymes. They had no objective evidence whatsoever. And here he is making the diagnosis of a myocardial infarction, and he is calling on the phone. They brought the rhythm stripped in. It showed that he, in fact, had a myocardial infarction. He just nodded his head yes and said, "Move him up. They've got the bed ready. Just get him to the unit." And I related this story to Dr. Wirtz, and she said, "Well, do you think you could do the same thing with dogs?" Because she knew how she'd had her animals wired up. We weren't doing these animals for us. We were getting leftover animals that she was using in her American Heart Association, and we were just using them before they were sacrificed. So we were kind of piggybacking. We were doing this on a shoestring. And I said, "Yes, I suppose we could, because we're all wired the same." And so that's how this liaison began. And after we did a few dogs, she said, "I need to have a second clinician." And so I chose Dr. Vick because, like me, he was a multi-generational osteopathic brat with family members and a long, long history. He'd been trained in internal medicine, but he also had been raised with osteopathy, as had I. And we came up with a very simple little numeric code. Oh, hi, stranger.
Sure.
Hey, stranger.
How are you?
I'm still alive.
I can see that. It's nice to see you.
Yeah.
Friends about 30 years. Nice to see you.
So, this was challenging. I always believe in the KISS principle, keep it simple, stupid. So the idea was to make a very simple scale. We came up with a numeric scale. This is just based on tissue texture. I'd asked Dr. Max, I said, Dr. Max, would you show me what you just did? And he said, sure. We walked out to the patient. He said, now slide your hands under either side. You don't even have to lift the patient up on a gurney. You just kind of roll them from side to side, and you can get your hands down and palpate that interscapular region that sends sympathetic innervation to the heart. And he said, now push toward the ceiling, first with the left hand, then with the right hand. And clearly, because the left side of the heart is bigger, it dominates, and you could get much more stiffness. I mean, it was, once you feel acute visceral disease in the tissues, you will never forget it. And so this is what we set out to prove. We were using this in osteopathic medicine for about 80 years, but we didn't have any science to prove it. Now I hand it back to you.
Okay. The assessment is, like I said, includes looking at the symmetry of transverse processes, the mobility of the spinal segments, soft tissue quality.
I'll give you a hint. We both use soft tissue quality almost exclusively. The rest of that was just, you wrote that up.
Okay.
We never paid attention to where the transverse processes were.
But here we can see normal tissue would be pliable, uniform, non-tender. Well,
In other
how's
words,
a
normal.
dog going to communicate if something's sore? Well, believe me, they will flinch if you touch something that's not feeling well. With somatic dysfunction, contracted, irregular, signs of discomfort by the animal. So we came up with a scale. 1 meant that the tissue was soft, pliable, plastic, mobile, symmetric, no somatic dysfunction evident. 5, the tissue was hard, irregular, not pliable, resistant to induced movement, bilateral, and marked somatic dysfunction.
And 2, 3, and 4 were variations between those two extremes.
We also measured the electromyograph on the surface. We placed surface electrodes at T4 to 5 and T11 to 12. We collected a signal for 30 seconds during each acquisition period. And I put in here an increase in mean power and a shift to high frequency was evidence of muscle activation. We did statistics. This is one of the strip charts from one of the experiments. And what you can see here is we are measuring left ventricular pressure, segment length changes, the amount of contraction during each heartbeat in the anterior or the region served by the LAD. So this is going to be end diastolic length, and down here would be end systolic length. This is the region served by the circumflex. Again, end diastolic length up here, end systolic length. So he's shortening this much. We're measuring cardiac output, circumflex coronary blood flow in mils per minute per gram, circumflex blood pressure, and aortic blood pressure. This is going to be during the control period. And then right here, we begin a stenosis. As soon as we stenose the vessel, I decrease blood flow as best I could to about 50 to 60% of normal. When you decrease blood flow, the blood pressure distal to the occluder is going to go down, and it stayed reduced for the whole length of the occlusion. That's important because if this dog had significant coronary collateral vessels that opened up during the occlusion, what we would see is coronary blood pressure would slowly creep up back to normal, and he didn't do that. So there were no collateral vessels serving that area. So coronary blood flow and blood pressure stayed reduced the whole time. What we saw during the occlusion was a decrease in the amount of contraction in that posterior wall of the heart, no changes in the anterior wall of the heart. So that reduction in coronary blood flow led to a 16% decrease in contractility, DPDT max, a 14% decrease in segment shortening, the percent segment shortening in that posterior region, a decrease in coronary blood pressure, an increase in heart rate. Well, if we're inducing a sympathetic reflex, sympathetic firing to the heart is going to increase heart rate in order to increase cardiac output, to increase blood flow, in order to reestablish normal coronary blood flow. So that is one evidence that we did induce a significant sympathetic reflex. And I'll show you the other evidence in a second. There were no changes in systolic pressure, end diastolic pressure, mean arterial pressure, or anterior wall segment shortening, which was anticipated. Remember, this is a 50 to 60% stenosis. When do patients start complaining about significant events with coronary occlusion? Well, when you get to 80 to 90% occlusion. So this was just a mild occlusion physiologically. This is a table.
The dogs would never evidence any discomfort when we were occluding them.
No.
You could not tell from their demeanor that we were occluding.
Showing actual numbers, we can again see systolic pressure was not changed during control. This is the sham stenosis, another control region during coronary stenosis, and then we kept measuring it. Here I'm just showing the data 15 minutes after release of the occlusion. End diastolic pressure did not change. We did see a significant decrease in DPDT max, so contractility of the heart was significantly reduced. Heart rate was significantly increased. No change in mean arterial pressure. Segment shortening reduced from almost 15% shortening to 9% shortening. Cardiac output was significantly reduced. And of course, I, with the occlusion, reduced coronary blood flow, and as a result, coronary blood pressure was reduced. So what was the evidence of a sympathetic reflex? The increase in heart rate. Another way to show that there is an increase in sympathetic tone to the heart during myocardial ischemia is to try and chemically block the effect of sympathetic firing. And one of the ways is to, a lot of my research was in the area of neural control of coronary blood flow during stress, it's particularly sympathetic neural control and the existence of an alpha receptor mediated coronary constriction during stress. So whenever you're undergoing stress, like exercise, any kind of exertion or myocardial ischemia, the sympathetic nerves would start firing. Well, all our blood vessels have alpha receptors on it. That sympathetic tone that increases is causing increased release of catecholamines, norepinephrine at those alpha receptors, and you get a very significant alpha receptor coronary vasoconstriction. If you give an alpha blocker like prazosin, a selective alpha-1 receptor blocker, you remove that sympathetic tone on those blood vessels and blood flow increases. And that's exactly what we saw. I would give through that coronary catheter about a little bit, 0.5 milligrams of prazosin. And it would circulate, it goes to the posterior wall of the heart, and it blocked the alpha receptors, and coronary blood flow increased 20%. So that's another demonstration that there was a sympathetic reflex. So here we see during sham stenosis, if we gave prazosin in the resting condition, there's very little sympathetic mediated coronary constriction, but during the stenosis, there was an average of about 23% increase in coronary blood flow, indicating a significant sympathetic mediated reflex. So after we induced this viscerosomatic reflex, we saw evidence of tissue changes, increased muscular tone, and an increase in EMG activity in that region. And if we looked at this is showing the palpatory assessment, 1 to 5, in the T2 to 5 area, the T11 to 12 area. In control, the measurement was 1, and down in the control region, 1.3. During stenosis, it averaged 3.8, indicating the words that I got from Dr. Dickey was it's bilateral hard, somatic dysfunction, marked muscle tension. And it was still elevated after 15 minutes. What was surprising was down here in the T11-12, it was slightly elevated as well, not as much. But it was almost returned to normal by 15 minutes. Correlating that with electromyograph activity, we saw that in control conditions, it was about 14.5 microvolts, but it increased to almost 26 microvolts during stenosis in the T2 to 5 area, which indicated to us that there was a significant increase in muscle tone as a result of the myocardial ischemia. To confirm that it's the sympathetic nerves that mediated this cardio-somatic interaction, 3 dogs were sympathectomized, the ventricle was sympathectomized, and we did the experiments in them. But in contrast to those neurally intact dogs, we saw all these changes that we saw in the normal dog, but we didn't see any changes in the palpatory assessment or the EMG. So in contrast, there was no palpatory or EMG evidence of paraspinal muscle tone. So throughout the whole experiment, muscle tension and texture remained soft and compliant bilaterally. The score remained at 1.25 during stenosis. The EMG remained at 14.7 microvolts during the stenosis. So when you destroy the sympathetic nerves and interrupt that sympathetic reflex originating from that ischemic area in the heart, there is no impulses going into the spinal cord to synapse on somatic nerves to cause a change in somatic function. So we accepted our primary hypothesis. There was evidence for a segmental sympathetic mediated viscerosomatic interaction initiated by the coronary occlusion and affecting predominantly the T2 to T5 paraspinal muscle groups. And that we also concluded that cardiac afferent activity can cause simultaneous activation of deep muscle groups through a reflex pathway or some other form of physiological interdependency that is highly localized. And it was the reviewers of the Journal of Applied Physiology that suggested we add that last sentence in order to get the paper published. Whether this is a reflex mechanism, facilitation, or some other physiological interdependency remains to be determined. And again, I think we are convinced it's the physiologist.
I don't know how they can say that with all this information in the sympathectomy, that this thing is not clearly sympathetically mediated. Is insane, in my opinion.
Yeah, I agree.
But you do. It took us 10 years to get somebody to bite on this and to publish it.
So, strengths of the study, I think the use of conscious dogs, they were healthy. They didn't have existing coronary artery or cardiac diseases. They weren't on any medications, which is very different from what was published previously with anecdotal data that stated that patients with having a myocardial infarct had palpatory evidence of increased muscle tone. These were healthy animals, and we controlled the conditions. And the ischemia was created under very tightly controlled conditions. I think the direct measurement of ischemia, we demonstrated the response to the somatic tissues is immediate, occurred within a minute. It was reversible. Within 30 minutes, we were back to normal. And it was mediated by sympathetic connections. Some of the limitations were that the manual assessments, manual palpatory assessments do more than just motor or muscle responses. They could include pseudomotor responses that we did not measure, and hopefully you folks already know what pseudomotor covers, right? Dr. Dickey, what is pseudomotor?
Well, that's sweat, and actually in a dog with hair, I never considered that would probably be valid in a human. And a hairless mammal, it would be.
Yeah, I think here, pseudomotor, if you're measuring on humans, your skin temperature is expected to increase, sweating.
That's where the diaphoresis
moisture,
comes from.
But that's not going to be true in this animal model because dogs release body heat by totally different mechanisms than we do.
Their tongue.
Their tongue, their ears, the pads of their feet. So that's why I put here, pseudomotor responses differ between human and canine models. So we have to, I agree, we have to be careful in extrapolating data from animal models to human models. But I think in this case, we're getting pretty, the results have been similar. We also have to keep in mind the anatomy and function of the muscles between humans, which are biped, and dogs, which are quadruped. They may use those paraspinal muscles and the deeper muscles a lot different than humans do. So we have to keep that in mind. But in any case, how else could we measure what we did? Again, use human models, humans that would be willing to have brief episodes of myocardial ischemia and also have their hearts denervated. And I don't think I would get too many volunteers.
It's not the heart. It's the surgery necessary to implant all that hardware that would give me a little trouble.
Have all these pretty little wires and catheters coming out your back. That would be nice. But I think we did contribute to the practice of medicine that manual palpatory assessments will correlate with visceral organ dysfunction. And I think this is an important thing to keep in mind. Like I said, going into this study, I was a complete non-believer, but Dr. Dickey and Dr. Vick were 95% accurate when they would stop and say, this dog has myocardial ischemia.
Note this.
And I will always remember.
How many diagnostic tools are there that are 95% accurate in medicine?
There was one dog I did, this was.
Oh, good. Walking down the hall?
No. We did this experiment on one particular animal, and when Dr. Dickey left the lab that day, he said, there's something wrong with that dog. There's something wrong from him the minute I touched him.
It's the control.
And
now,
no, the control was high. This dog, I induced renal artery stenosis, and he had renovascular hypertension.
We picked 11, 12 as the control because there's nothing we could do to the heart that should have affected the tissue tone at the thoracolumbar area. And yet this dog, she said, look, I tried every way in the world to fool these guys, and I couldn't do it. She couldn't fool us because our job was really very simple. We simply had a very simple 5-step scale to work with. We had very definite tissue criteria, and we simply wrote down what we felt, okay? And let the chips fall when they were. We were blinded. We didn't know, and she was trying every trick in the book to try to fool us. And it didn't do her any good because all we were paying attention to was how the tissues felt and how they responded. But I felt it necessary. We were finished with this dog. We were leaving for the day. Dr. Gordon and I were walking down the hall, and I said, Patricia, I have to bring this up. I said, I had to write down on the paper the fact the control area, there is something wrong because the control area was as irritated as the experimental area. And it remained that way throughout the experiment. And don't ever play poker with this lady because she gave me the deadpan look and she said, oh really, I'll have to look into that. Now she knew that she was using that particular dog to induce renal hypertension by putting an occluder on the renal artery. And she hadn't bothered to share that information with any of us. And I was worried that we were going to get skewed data here, because there's something wrong either with me or with this dog, because my control area, which should be pliable and loose and a 1 all the way through, was a 4 or 5 all the way through. And she didn't tell me until the paper was published. She didn't break the code and tell me this until we had this thing published. And actually, she didn't tell me at all. She was presenting it to her PhD colleagues over at lunchtime one day.
You got to have some fun. There was one other way, and I feel fortunate that my surgical skills are good enough that it never happened. It only rarely happened that the instrumentation that you put on this circumflex artery can cause that artery to stenose. You can have such a tissue reaction to all these probes and stuff, where the vessel develops a lot of scar tissue and it occludes. We would pick that up immediately in the fact that if that were the case, when you release an occlusion, you expect to see this huge reactive hyperemic response. If they were stenosed from a lot of scar tissue due to the instrumentation, we wouldn't see that. And we wouldn't see, blood flow would not be normal at about 1.3 mils per minute per gram. We would see much reduced contraction.
We got a question at the back. You guys, you want to keep that in mind.
All right. This is for Dr. Dickey. I remember 2 years and a month ago, you came into this classroom and you gave us a speech on osteopathic history.
Correct. That was the last time I did that.
And you came in, and I will never forget this. You ended it with, be a good, forgive me, damn D.O. And you said
there was no F.
No. Yeah, that's what I'm just saying.
Be a damn good D.O.
Right.
You're always going to be a damn D.O., so be a damn good D.O.
That's what it was. Yeah, and I'll never forget that. And my question was I guess, why are you still retired? Why don't you come join us?
Because I have neurologic deficits that aren't going to get any better. In fact, they're slowly getting worse. I worked hard for 4 years. I was forced to retire on disability in 2008, and I spent the last 4 years getting as healthy as I possibly can. And now that I'm starting to feel better, I'm getting feisty, and I'm willing to go on the warpath and take this thing on the road.
I was going to say, we enjoy having you here.
While I'm here, take advantage of me, because I'm building a retirement home up in the Ozarks, and as soon as it's finished, I'm gone. I'm getting out of the Metroplex. But Dr. Gortz and I have ideas. I need to present this to the cardiologist. The fact that we got this published and we had to scrub it between each rejection, take something more osteopathic out of it. I got Steffinger, the editor in the Somatic Connection. I gave him my last printed copy of the paper, and he put it in the Somatic Connection last year. But we had de-osteopathicized this paper to the degree that he failed to pick up on the fine points in his summary, and that's all they do is summarize. So we need to take matters into our own hands and get this paper into the hands of the osteopathic community. Now, I had insisted that it be in a basic science journal. I have regretted that. There was going to be a second part where we could show that we could do something to the soma and we could produce vasodilatation in the heart. This would have closed the circle. Since it took us almost 10 years to get this article published, in that period of time, the animal rights activists in this country shut down the use of whole dog nationwide. There is not a single medical school in the United States that is doing dog research anymore. So what was going to be the easy part? To do about 13 or 14 dogs, since each one was going to be a terminal experiment. We will never be able to. We did one test dog, the last one.
Yep.
And when it became obvious that we were not going to get this thing published before I retired, and it wasn't, and I took Dr. Gwertz to dinner, and I said, look, I've got to know, that one dog that we did, were you able to see vasoconstriction? My concern was that a mechanical occluder would negate the ability to treat the soma and produce a visceral effect, that we've got this mechanical occluder in here. I said, were you able to see vasodilatation distal to the occluder? And how was she doing this? She was injecting microspherols in angstroms in brilliant colors, each color designating a different size spherol, to see how far down the capillary tree these spherols could migrate. And I said, were you able to see evidence of vasodilatation distal to the occluder? And she looked at me and she said, oh, yes. Now that is the most stinging thing in my career, because I know I've done it. I've done it in the hospital. I've done it as a house officer. I've done it as a physician. We were going to prove both ends of the osteopathic theory. Okay, we proved the hard part. That's why we started with this. But if I hadn't insisted on a basic science journal and had just had it published in the JAOA, we probably would have gotten both parts done before they shut down dog research in this country. And that's the part that the dominant medical profession is not willing to extend to us. Well, of course, everybody knows you diagnose myocardial infarction based upon these somatic manifestations such as crushing arm or jaw pain or chest pain. But there's nothing you can do to the soma of the body that's going to affect the viscera. Wrong. We've been doing it for 150 years. And she was able to see that in the one dog that we did. But one does not a series make. And unfortunately, we're not going to be able to do that second part.
I think ever since we got this pleasure, I've been thinking, how can this be used clinically? Because when you have a patient coming into the emergency department with a heart attack, you're going to make that EKG measurement and you're going to take life-saving steps for this patient. But it's become very apparent over the last few years that women's symptoms of myocardial ischemia are very, very different compared to men. We have flu-like symptoms. We just have little aches and pains. We don't get that crushing chest pain that radiates up to the jaw. But since myocardial ischemia is present, you probably will be able to palpate it at T2 to T5 and use that as a diagnostic
The interscapular
tool.
region will not know whether you're a male or female. The autonomic nervous system does not know that. You will have, because I can tell you from hospital experience, you will have the same feel. Now,
Except for the woman that comes to the physician's office saying, I don't feel well, and they're in a full-blown myocardial infarct.
do you remember Floyd,
Yes,
the nurse over in medicine?
yes.
He showed up in my office. He was an on-again, off-again patient. And I worked on him, and he had a particularly irritated, angry, acute somatic dysfunction at about T3. And I was able to fix it. And he showed up 2 days later, and the thing was back again, and it was just as bad. And I started asking him, have you a family history of heart disease? No. This, that, and the other. Is anybody, da-da-da. I'm trying to look. I said, look, Floyd, and this was, he'd had a career as an RN in the Air Force, and then when he retired, he came here, and he worked here for about 20 years before he finally retired for good. A few days later, it was March, it was windy, the hospital stood on this location. He was pushing a 300-pound patient in a wheelchair across the street to get an x-ray, and when he got back, so he was doing his own stress test per se, you might say, and when he got back, he felt a little funny, and he mentioned it. And one of the residents in medicine was smart enough to put him on a table and get an EKG, which showed that he was in trouble. They immediately took him to the cath lab, and he had marked occlusion of at least 2 different vessels. And I had been asking him, I said, look, when I feel this kind of tissue texture, Floyd, I have to be concerned that you have visceral disease. And that's all I knew. I have sent patients just based on palpation to a cardiologist for a stress test, and they wound up being bypassed as a result. I saved them the heart attack. Now, if you believe in this, if you see this in action, if you understand the neurology of this, you have an edge that no other physician has. You can diagnose diseases that the majority medical schools cannot do. You have something extra to offer the patient. Now, is this going to replace modern medicine? I hope not. Not when I have my heart attack. But if you're quizzical about is he or isn't he, the tissues will tell you. The body doesn't. Dr. I.M. Core, you know who Dr. Core was? He was one of the fathers of, well, he was here for many years prior to his retirement. And he told me just a few weeks before his retirement at age 80, we were walking down the hall, and he stopped and he summarized 30 years of clinical research. He said, Jerry, every time you correct somatic dysfunction, you return to the autonomic nervous system the ability to make appropriate moment-to-moment decisions. So when we treat visceral disease, we're not treating cause, we're treating effect. But we return to the body for at least a short period of time, an hour or two, the ability to make appropriate decisions. My father, in the pre-antibiotic days, he practiced 15 years before penicillin. He would sit up, sleep in a chair with his patients at night with a wind-up alarm clock, wake himself up every 2 hours, and work on their thoracic and rib cage area, and because it's cardiopulmonary. And he pulled many pneumonia patients through in the 30s and in the 40s with his hands when there was no other form of treatment available. Now, you'll not have that opportunity. For you, it will always be a secondary treatment. But the fact is, I have picked up ulcers, I have picked up pancreatitis, I have picked up impending myocardial infarctions just by knowing my levels of innervation and by knowing what the tissue texture changes feel like. And this is where you need to have somebody like I did who had been doing it for years. I asked him, show me what you did, and he walked me through it, and once I felt it, I never had to ask anybody what it felt like again. I knew. And that's all I brought to this experiment, was that knowing, that feel.
We have a question.
I have a question. So why is it so difficult to have that experiment in the ER? You have a ton of patients with chest pain coming into the ER every day. Couldn't we have a physician outside of the ER physician blinded to the actual results?
This experience that I'm relating to you with Dr. Gutenson was in the ER.
Exactly. So why don't we...
Because I was at Kirksville with a classically trained osteopathic physician that was older, and nobody thinks about it, nobody believes in it. This is why we did this work. I saw a glaring scientific hole. We're using this for 100 years to diagnose disease, and yet
I think you need cardiologists, you need ER physicians that are PIs on clinical trials that are willing to let it happen.
the physicians and the scientists look at us and say, show us the data, show us the studies.
Yeah.
And we didn't have the studies. And so this was an opportunity to fill a hole that existed in this profession. Still didn't do us a great favor when he went from theory to clinical application without an intervening research phase. And after 100 years of it working, we still hadn't done that intervening research phase. Well, this is so clinically tight and so scientifically tight that we have filled that hole in the osteopathic knowledge base with this experiment. And I wish we could have done more.
Yep.
I wish we could have shown that we could affect blood flow to the heart. I was treating patients in the hospital in Kirksville after their MIs. Not with high velocity, but with gentle techniques. I was ironing out the autonomic nervous system. If you want to get healing of the area of myocardial infarction, what do you need? All the blood you can get. So anything you can do to vasodilate the coronary arteries is going to work toward the best possible outcome for that patient and the healing. And this is what we're going to try to get. We're not going to ask you to go to the 19th century. You're in the 21st century. But what we discovered in the 19th century is just as valid now as it was then. It's adjunct treatment now. It's not primary treatment. This is our edge. This gets the patient out of the hospital. You will lose fewer patients if you incorporate. You will have fewer people going to heart attack or to perforated ulcers if you learn to feel the tissues and use them as a diagnostic tool. This man who showed me was a board-certified internist, but he had been trained in the 40s. Okay? It's almost a lost art. You need to find a clinician who can show you these things.
A class at 10 o'clock.
Yeah.
So we got a call. Before I end, I want to. This was one of my favorite research animals. I loved this dog. So I had to show her picture. But I want to thank you, Dr. Dickey, for coming. It was a big surprise to me.
When she had this beautiful German Shepherd, she said, "This is going to break your heart." And when she finally got around to occluding him, I palpated him. I had my back turned to her, and she turned and she said, "Okay, do your evaluation." And I felt his back, and I looked at her, and I said, "This is a terrible thing you're doing to a beautiful animal like this." And that was the one time that the corners of her mouth turned up, when the poker face broke, because she was busted. Thank you for your attention.
But thank you very much. You have any questions, you want to talk about it, shoot me an email. Otherwise, I will see you either in musculoskeletal or GI.